Okay, so we're going to continue after the break. Now, we're back on case 5, and we're asked to assess a person, a 39-year-old man, who comes to your office as part of routine screening examination for a new job that he's starting. He's without symptoms and feels generally well. He's HIV positive and has had a purified protein derivative skin test, PPD, in the past. His CD4 cell count is 550, and he is on no medications. He comes to see you for his routine examination for reading of his purified protein derivative skin test with your nurse placed 2 days ago. His temperature is normal, blood pressure is okay, pulse is 72 per minute, so respiratory rate is 12. The physical examination is normal, and ears, nose, and throat and everything seems okay, and the chest is clear. And cardiovascular examination is again normal. His abdomen is normal, so the examination reveals nothing. There is no lymphadenopathy present. His skin test shows 8 millimeter in duration. So the question is, what does 8 millimeter, a PPD of 8 millimeter in an HIV patient mean? Well, we know that the category that we consider positive for over 5 millimeters are the immunocompromised patients like HIV and other immunocompromised patients. So these are people on chronic steroids, on immunosuppressive agents, on bone marrow transplant patients, and so forth. That's one category, and the other is that we consider positive 5 millimeters on is the case of a close contact of active TB. So somebody was found to have active pulmonary tuberculosis, and the person that you're evaluating was a close contact of this person. Close contact means they are usually either working closely together, they live in the same house. It usually doesn't mean that you saw them only once. Close contact means you came into contact with them at least a couple of times or so. Active TB means active pulmonary tuberculosis. We don't mean just a positive PPD. So it means that this person was treated for active pulmonary tuberculosis to be considered a close contact of this person. These people are considered 5 millimeters or over to be positive. So for example, let's say a person who's 70 years old got diagnosed with active pulmonary tuberculosis. And you ask him a question, he came in with fever, with cough and so forth, with weight loss, and you found that the acid-fast bacilli is positive. You isolate this person and you hospitalize him. And you start with 4 anti-TB medications because this person has active TB. You ask him, are you living at home with somebody? And he tells you, yes, my wife or my daughter. Well, that person, you go back and ask her questions and she has no symptoms. You place a PPD on her. Over 5 millimeters is considered positive in this patient. This person is a close contact of a case of active TB. Okay? And the third one, the last one, that you probably don't have to know, is a chest x-ray that shows old active TB. Old TB. So, for example, if all of a sudden you do a routine x-ray on somebody and you find scarring here, there you go, in the apex. That's consistent with old TB. A good radiologist could tell you if that's active or not. Okay? So, old TB on the x-ray. Non-treated, of course. Non-treated. So all these people are considered positive if they have 5 millimeters or over. So in this case, this person is positive. So now the question becomes in this patient, does this patient have active TB? We're right here. Does this patient have active TB? Or does the patient have what is called now, they like to call latent TB. Latent TB. That's the terminology they use now, latent TB. That the patient had the infection in the past, right, kind of walled it off, but it's latent. It could reactivate sometime later when the patient, for some reason, something happens to them, their immune system goes down, they could have this TB activated again. So how do we answer this question? Well, one is the history, no symptoms, right, and the physical, no findings. So normal physical exam, no symptoms, normal physical exam, chest x-ray, normal, means that this patient has latent TB. No symptoms, normal physical exam, chest x-ray normal, this patient has latent TB. Then, and only then, do you consider treating for latent TB, which means latent TB means only isoniazid for 6 to 9 months, depending on the patient. Usually the immunocompromised patients, you like to go 9 months. So let me say this again. Once a PPD is positive on a patient, it tells you that this patient is infected with tuberculosis. Your next question now becomes, does this patient have active TB or non-active TB, old infection, which is now called latent TB? The only way you can know that is if you do a careful history and physical. Usually the people with latent TB have no symptoms and have a normal physical, and the chest x-ray is normal. Okay? Doesn't show active TB. Now be careful, I told you here that a person with an OTB on the x-ray is considered positive. So what I mean by chest x-ray normal or old TB, OTB, non-active TB. So that's important. Okay? So we cannot treat a patient for latent TB unless you know the patient has no symptoms and you know that the patient has a normal chest x-ray. You cannot do that because the patient may have active TB. So positive PPD means nothing unless you have this here. You don't know which one it is. Is it active or latent? This gets isoniazid only. This gets what? 4 drugs. Okay? So that's why here, in this case, what do? They do a chest x-ray. The patient had a normal physical, normal history. They did a chest x-ray. Now it's normal. Now we could talk about latent TB. They also got liver function tests because one of the side effects of isoniazid is what? Liver toxicity. That's one of the side effects. We need to get liver function tests. If those liver function tests increase to 2 to 3 times the normal, the upper limits of normal, then you decide to stop the isoniazid. Not just a little bit elevated. It has to be at least 2-3 times the upper limits of normal. Then you decide to stop isoniazid. One other toxicity of isoniazid is the peripheral neuropathy. That's why, in a kind of anemia called sideroblastic anemia, but the peripheral neuropathy is important. That's why when we give isoniazid, we give it along with vitamin B6, pyridoxine. When we give 4 drugs, one of them is isoniazid, we also give plus B6 again here. So the patient usually tells you, I took 2 drugs, doctor, for latent TB. That's what they mean. They took isoniazid and B6. Okay? So very good. So that's the way you think about this high-risk category. This high-risk category here, whatever time in their life they become positive, they should be treated for latent TB, if they have latent TB, whatever time in their life. There's no question about it. There's also an intermediate category that we consider over 10 millimeters, equal to or over 10 millimeters. This is intermediate. So they're not as high risk as these patients. These patients, to make it simple for your boards, these patients will get treated any time in their life too. So this category and this category will get treated any time if they have latent TB. In this category, we have people from endemic areas. So think about endemic areas outside of the United States, right? There's some places in Europe and Central America and Africa, everywhere, that are endemic. And if that's the case, if they come from an endemic area, they've lived in an endemic area, 10 millimeters over is considered positive. Now, we have endemic areas in the United States, so you should think about this in a whole different frame of mind, right? What are endemic areas in this country? Well, jails, right? In the United States. Jails, nursing homes, right? Hospitals, shelters. So if this person lives or works in any of these areas, or they come from endemic area, you think of endemic area outside the United States, endemic areas in the United States. It's a good way to remember this. These people in this category. The second big group of diseases here are chronic diseases. Chronic diseases, especially lung diseases. For example, silicosis. Now, silicosis poses a specific problem because if you remember where silicosis usually affects the lungs, it's usually the upper lobes. And that's what post-primary TB affects, the upper lungs. So now you got scarring in the upper lungs in silicosis, and you got a cavity there of tuberculosis. You can't see it because of the scarring. So it's very important. Other chronic diseases like chronic renal failure and so forth belong in this category. Some people refer to diabetes in this category and so forth. So the bottom line here, what I want you to remember is there's two groups here that you need to think about. Endemic, people that come from endemic areas outside the United States and in the United States that work in endemic area or live in endemic area, and people with chronic diseases. That's the bottom line. And the last category is the ones that usually don't have any risk factors. No risk factors. No risk factors here. And these people are over 15 millimeters. Now, some people will tell you, well, this is everybody's got some kind of risk factor. Yeah, but some people don't. So in big cities like Washington and New York and Chicago, there's really, most people do have some kind of risk factors, but there's areas in the United States that have 1 or 2 cases of TB every couple of years. You go out to the west, to Oregon and places like that, and they don't have a lot of TB. So there are people that belong in this category. Okay? Very good. So, no risk factors over 15 millimeters, right? Intermediate, over 10 millimeters. High risk, over 5 millimeters. Now the question is, you know what's positive. When do we treat these patients? Well, I just told you before, this category and this category here gets treated when? At any time in their life. When they become positive. There are some exceptions. You don't have to know them. You just have to know that any time in their life these people become positive, they should get treated. Now, this is the question. With 15 millimeters, there's a couple of questions here that you may see old recommendations on and some of the newer ones, and some people go back and forth on this. This is what happens with 15 millimeter patients. If the patient is less than 35 years of age, the benefits from isoniazid outweigh the risks of hepatitis. That's what it really comes down to it. So these people have benefit. And thus, if a patient is 35 years of age or less, they will get treated with isoniazid 6 months or so, plus pyridoxine. That's what most people still believe. I'll tell you what the real scenario is, but that's what most people believe. The reason is that you say somebody's less than 35 years of age, they likely got the infection somewhere recent, they will benefit from isoniazid. It seems that when the patient gets infected, it's the first couple of years that are the most risky to get active tuberculosis. So you say, this guy's young, they won't likely get hepatitis, they benefit from isoniazid. And this is based on studies done 25, 30 years ago that some people still question because these people were given isoniazid, let out into the community, nobody checked their liver function tests, right? So what do you think happened to them? They developed hepatitis. So some people said if the patient is over 35 years of age, especially an older individual, the side effects from the hepatitis outweigh the benefits. And again, this was based on older studies. Now, we don't do that anymore. If a patient is put on isoniazid, they come to you every couple of months to check their liver enzymes. And if they go 2 to 3 times the normal, upper limits of normal, you stop them. So they don't develop hepatitis. We don't have episodes like this anymore, unless the patient doesn't do what you tell them. So anyway, but the recommendations say that over 35 years of age, maybe there's no benefit, and maybe you should not treat and just watch. Over the next couple of years, you will hear a lot of conversation about this recommendation here. And most likely, when most people are finishing residency, these recommendations will have changed. And they will tell you, listen, you should go ahead and treat even this person. Even treat this person. Okay? So, but for right now, you probably should remember this. Now, there's one exception here. There's one exception. If people are infected with tuberculosis and they are recent converters, they're infected recently, I told you, it's the first couple of years that they have a higher risk of getting active TB. So, they tell you here, all bets are off if the person is a recent converter. You don't care if the person is 90 years of age. If they have recent conversion, then they need to be treated. What's recent conversion? You placed the PPD last year. It was negative. You place it this year, it's positive. That's a recent conversion. Within the last year or two. That's a recent conversion. That patient, recent conversion, gets treated at all ages. So if it's a recent conversion, you don't care that they are no risk or low risk. You don't care. They will get treated. That's the bottom line. So those are the categories. You need to know the categories when a positive PPD is a positive PPD. And the second thing you need to know is when do we treat these patients. These two categories, you don't have to know. They get treated all the time. Recent converters, you don't have to worry about. They get treated all the time. These people, though, are a little bit of a question. So they may give you a patient, for example, that is 72 years old, right? A man. No risk factors, living out and having no risk factors at all, and now goes and gets a PPD because he's going to be admitted to a long-term facility. Now, he hasn't lived in a long-term facility before, right? So he's low risk. He's got no risk factors. And they place a PPD on him. And the PPD winds up to be 18 millimeters. So that's positive, right? Well, maybe you don't have to treat this person. unless you know this is a recent conversion. They told you last year, well, it was negative. Because he falls here and he's pretty old. They won't benefit from isoniazid. That's the only probably exception to the rule here. Okay? Good. The last thing I want to say here is about the BCG. The BCG, tuberculosis vaccine, should not be used to say this patient has a positive PPD because of the BCG. Even though patients have received the BCG, in reality the BCG causes maybe a mild positive PPD within the first 5 to 8 years once you receive it. Mild positive means usually 10 millimeters or less. So in this country, we don't accept this in the history as a cause of a positive PPD. They may ask you about this, because if you tell them this guy's got 15 millimeter induration on the PPD, and you tell them, yes, it's because they received the BCG, that's wrong. In this country, they don't want you to accept that. They want you to say that it's likely that this patient is infected and consider treating them, depending on what category they belong to. In reality, the BCG does offer some protection from the studies we know in young kids, in children, for disseminated tuberculosis. You don't get the meningitis as common, you don't get miliary TB as common. So it offers some protection. The studies are very variable, anywhere from 10 to 80% protection. So in this country, we're not an endemic area. That's what the Americans think. So we should not use the BCG at all, and we shouldn't use it in the history to think that this patient developed a PPD positive because of the BCG. So for the boards, I don't care what you do in your clinical practice, but for the boards, when they give you a patient with a BCG, you're going to write that off. You're going to write it off. And you're going to consider the patient just like here. If they belong to one of these categories and the PPD is positive, you consider treating them. I guarantee you. So don't be fooled by that. Especially, I told you, it usually causes a mild positive PPD in the first 8 years. So if this guy had the BCG 20 years ago, right, that patient should not have a 12 millimeter induration or a 15 millimeter induration. That's a true positive. Okay? So don't worry about the BCG. Just evaluate the patient like they didn't have it. All right? So good. So that's the bottom line. That's the treatment of latent TB. There's some reports that if you use in patients with HIV, you use a combination of rifampin for 2-3 months. The combination of rifampin and the thambutol or pyrazinamide, depending on which study you're looking at, for a short while, that this short course is as good as the 6 to 9 months course of isoniazid. There have been reports of extreme toxicity to the liver with these combinations. So right now, I can't recommend them until there's newer studies. The studies show that the patients benefit. There's recent reports from the CDC that show that this combination is very toxic in these patients, so be aware of that. And this is only for HIV patients. So it seems maybe it's more toxic because these patients are taking other medications, a myriad of other treatments. Okay? So we're going to stick with isoniazid for now. Everybody all right there? Good. Let's look at another case, though, go a little bit further down and look at what it means case 6 to have active TB. So look at this guy. A 39-year-old homeless man comes to the clinic for a several-month history of productive coughs. He's also reported night fevers up to 103 associated with chills. During the past 6 months, he has a 20-pound weight loss. He's a non-smoker, and his medical history is significant for hospitalization of pneumonia 4 months ago. He was lost to follow-up after discharge. His temperature is 38.4, blood pressure 105/60, pulse is 88, respiratory rate is 20. He is thin, unkept, appearing in no acute distress. He has bitemporal wasting, poor dentition, multiple 1 to 2 centimeter mobile cervical lymph nodes. His cardiac and pulmonary examinations are normal. Examination of the abdomen is benign, and extremities are normal. So now you got a syndrome that you could see this patient has symptoms. We're not talking about a non-symptomatic patient like we did before. So lymphadenopathy, wasting, night sweats, and all this stuff, especially in the patient that has risk factors. This guy was a homeless guy and lived probably in shelters and so forth. So you definitely have to think now about TB. But if it's TB that you're thinking about, it's not latent TB. We're talking about active TB now, right? We're not talking about latent TB anymore. There's other things that could cause similar symptoms. One of them is, like they say here, is lung abscess. Sometimes lung abscess occurs in people that are alcoholics or have seizure disorders because they aspirate foreign bodies or aspirate flora in the mouth and cause lung abscesses. And sometimes a lung abscess has the same symptoms as tuberculosis. Usually they may go for 1 month, 2 months, where they have night sweats. The type of abscess is usually, the abscess, the organisms that are associated with the abscesses are usually anaerobes. So they're not fast-growing, they're not aggressive like pneumococcus or Haemophilus influenza, where the disease usually is short-lived. They go on sometimes for weeks and months. And of course you think about other stuff like lung cancer in this patient. Lung cancer sometimes, he's a little bit young. He's a little bit young for lung cancer, 39 years of age, but definitely something to think about. Bronchiectasis, we're going to talk a little bit about this disease maybe a little bit later also. Bronchiectasis is what? Who are people that get bronchiectasis? It's usually people that have lung infections over and over again, cystic fibrosis, people with Cartaginer syndrome and so forth. And people with bronchiectasis, they usually complain of very productive cough. They tell you every day, I fill a glass of water with my cough. The cough is purulent, foul-smelling. They get recurrent infections. We don't have anything in the history to tell us about something like that, so that's less likely. And of course, you think about a pneumonia, post-obstructive pneumonia. This would not be a community pneumonia because, again, they're short-lived. So the first test to do in this person, the first test, is get a chest X-ray, because it will differentiate between all these 3-4 things that you're thinking about. And of course, in the results of this, you find a cavitary lesion in the right upper lobe. So symptoms consistent with tuberculosis. Cavitary lesion in the apices, this is likely active tuberculosis. The next step here is to isolate the patient. Although tuberculosis is probably less infective than we think, than we always assume, it's less infective, it's not very infective, but definitely this poses a big problem. So this patient definitely needs to be isolated. Your next step after that is document that this patient has active TB. There's 2 things that you do. One is stain the sputum for acid-fast bacilli. This is quick. It's quick. It should come back in about a day or 2. Now, acid-fast bacilli is a good test for pulmonary tuberculosis. It's not, though, 100% sensitive. You miss a good percent of the cases depending on how much of the bacilli you have in the sputum. Also, it's not 100% specific, because if you take an HIV patient and they have low CD4s, you get their sputum, you stain them with acid-fast, they'll be positive, because other things cause acid-fast positive sputum. One of them is MAI, Mycobacterium avium intracellular. So other mycobacterium other than MTB may do it. So it's not 100% sensitive and it's not 100% specific, but in this patient with symptoms and a cavitary lesion, the likely diagnosis is pulmonary tuberculosis. Other things that cause positive AFB is nocardia sometimes, and rarely some Legionella species will do it. But these people should have different history, not a cavitary lesion in the apex. The second thing that's sent away, once they stain the sputum, it's usually the early morning sputum that you get, and if you can't get sputum, the patient doesn't have any productive cough, and you can't generate any sputum, you induce sputum. The pulmonary therapist goes by bedside and induces the sputum. So you get a good sample. So this sputum is then transferred to a culture. And this is the gold standard, the culture. The culture for MTB is the gold standard. There's a problem with this. How long does it take? Maybe up to 6 to 8 weeks for the culture to come back. Now, this culture will not only definitively tell you what mycobacterium it is and definitively diagnose MTB, but it will also give you sensitivities. This is important, especially in big cities where we know multi-resistant TB is generated. So it's very important to have this person on at least 4 drugs until this culture comes back. Very important. Because if it comes back multi-drug resistant and you only got on rifampin and isoniazid, now you're kind of zapped. And this person would likely have infected other people. So the sensitivities you get back in 6 to 8 weeks, and you get the definitive study back in 6 to 8 weeks. What does it mean? It means that a patient with a cavitary lesion and symptoms consistent with tuberculosis, even if your AFB is negative, even if this is negative, because this is not 100% sensitive, you still will assume tuberculosis and treat the patient until the cultures come back. So let me say this again. In a patient with a cavitary lesion in the lung and symptoms consistent with tuberculosis, you will treat this person as presumed active tuberculosis even if the AFB is negative. So if the AFB is negative, you treat and wait for the cultures. If the AFB is positive, you treat, right, and still wait for the cultures because now you're waiting for sensitivity. So your suspicion, your clinical suspicion is the one that drives you here, and that you've ruled other things out, that the lesion on the x-ray doesn't look like other things. Okay? Now, if the culture comes back negative, well, you've got to find an alternative diagnosis. If the culture comes back negative, well, you stop treatment here. Because it's not likely that, it's got to be something else. Okay? So that's the definitive study, but please know that the AFB is not for sure. So even 3 specimens of AFB miss about 20 to 30% of cases of active TB, which means you've got to treat these people. And that's what they did in this patient. They put him in respiratory isolation and spewed him for acid-fast bacillus in culture. The results in this case was positive. This patient had acid-fast bacilli, and they made the assumption that this was active pulmonary tuberculosis, and they started 4 drugs. What are the 4 drugs that you treat this patient with? And most of the patients, it's isoniazid, rifampin, ethambutol, and pyrazinamide. Those are the classic drugs. If the patient, after 6 to 8 weeks, has sensitive mycobacterium to everything, then you could stop these 2 and continue with isoniazid and rifampin. This is why you see in most of the regimens, you start 4 drugs, right? You continue them for 8 weeks or so. This is why after that they tell you ethambutol and pyrazinamide could be discontinued. Sensitive TB to all antibiotics, then continue isoniazid and rifampin only for 6 to 9 months. Usually we like to treat it as more the better. Okay? One last thing. A patient that has been treated fully for TB, they usually don't get TB again. Okay? It has been shown that people don't like to take TB medication. Even if you tell them you have active TB, they don't like to take it. About 60% of the patients will skip doses. And I don't mean skip doses 1 day or 2, I mean weeks. So now you have direct observation. These plans, these people that go and they give the isoniazid and rifampin to people because this is considered a hazard to society to have active TB, and they give the patient the medication, they watch them take it. These programs have been shown to make a really big difference. So they may ask you something about that. Especially in people that live in shelters and homeless, they have to go and do direct observation. Okay? Make sure that they take the medication. Once a PPD is positive, you never repeat the PPD again. Never repeat the PPD again. There's no reason to. If the patient tells you the PPD is positive, I've had it in the past, and it's positive, you don't repeat it again, because if you do, you sometimes get a reaction, a sensitivity reaction, severe sensitivity reaction, and necrosis of the area. So you never repeat that. Never repeat that. If it's positive, it's positive. If the patient didn't get treated before for latent TB, then you decide what to do, but you don't repeat the PPD. Okay? Good. Most cases of active TB, once you start them on 4 drugs, at about 2 weeks, right here, 2 weeks, they're usually non-infective. Usually non-infective. We know that from older studies. They're usually non-infective. So what they used to do in the past is put them in the hospital for 2 weeks in isolation, treat them with 4 drugs, send them home at 2 weeks. Nothing to worry about. Well, now you're a little bit more worried because of the multi-resistant tuberculosis. So now what most people tell you is you want the acid-fast bacilli in the sputum negative at least 3 times for the patient to be sent home. Not everybody agrees with that. But what I want you to know is why this has changed how we evaluate these patients. Because if you send them home 2 weeks, in 2 weeks, and 8 weeks down the line, now you get the culture back that it's resistant to isoniazid and rifampin, you're in trouble. The patient may still be infecting people. Okay, even though with the 4 drugs. So people are concerned about that, a little bit more concerned now. Okay, but usually, most cases of TB, 2 weeks, if they're resistant, at 2 weeks, they're non-infective. You could send them home. All right? In the children, children don't develop granulomas. So tuberculosis is a different process. They get primary TB, and adults get primary TB. It's usually in the lower lobes, like an infiltrate, like a pneumonia. And children don't wall off the infection. They don't get post-primary TB with a cavitation in the apex. What they do is, if they don't wall it off, is they get disseminated TB and TB meningitis, miliary TB. So the bottom line is, TB in children is a more aggressive disease. And you don't find cavitary lesions in children. Well, what is the clinical significance of this? When you have an adult, you have, this is primary TB, right? We said it affects the lower lobes, like a pneumonia. It looks just like a pneumonia. Then that's walled off, and then now you get later post-primary TB. And where does that affect? The upper lungs, right? The apex. So here you go. This is post-primary TB. Now, this happens in adults. It's the cavitary lesion here that is infective. This miliary TB, this pneumonitis, is not very infective. So it's usually adults that are infective. So in a classroom with one teacher and multiple kids that got active TB or have positive PPD, who you think infected them? It wasn't another kid, right? It was only the adult. It's only the adult that could develop cavitary tuberculosis and infect the children. Children are not infective. They don't infect each other. Okay? They don't infect each other. So if they give you a family with 3 children, 1 mother, or something like that, it's not the children that infected each other. It's the adults. You have to develop cavitary lesions for that. It's the cavitation that occurs that causes the infectiousness. Okay? Good. So know that. That's important. That's an important clinical scenario. So let's go a little bit further down. So that's your tuberculosis. They should have a couple questions on tuberculosis, both latent TB and active TB. Very important clinical problem. So a little bit further down, we're on case 7. And this patient is a 43-year-old woman, comes to your office for evaluation of persistent productive cough for the past 2 years. She has a long history of recurrent episodes of bronchitis for which she has taken multiple episodes of antibiotics. She was hospitalized. She was hospitalized for pneumonia twice as a teenager, and over the past 2 years, she has developed persistent congestion with cough productive up to 50 mLs daily, thick greenish yellow sputum. There is occasional blood streaking, and she denies any fevers right now, chills, or related symptoms. Her last course of antibiotics were approximately 3 months ago. She's a non-smoker and has no other significant history in the past. So now you get a little bit of a different history in this patient. Now the productive cough that we saw before with people with chronic obstructive lung diseases doesn't seem that this is the same productive cough that you got here. A 43-year-old woman that tells you, I produce 50 mLs per day with foul, greenish, productive cough, foul smelling. So clinically, this sounds like what disease? This sounds like bronchiectasis. And bronchiectasis is a disease that produces a lot of cough, very purulent, very productive. Her temperature is 99.9, 37.7. Blood pressure is 130/70. Her pulse is 88, and respirations are 20. She's got scatteronchi and bibasal, of course, crackles are audible on auscultation of the chest. The remainder of the examination is unremarkable. So, yes, you could think about chronic bronchitis in this patient, but usually the definition of chronic bronchitis, we said it's usually a smoker, it's usually productive cough, 2-3 months for consecutive years. That's the clinical definition of chronic bronchitis. This patient tells you, I produce cough every day, it's a lot of it, it's foul smelling, plus I have all these infections in the past, and has gone through multiple infections and pneumonias. So you definitely think of bronchiectasis. Now, bronchiectasis is defined, if you think about emphysema, where emphysema is defined as permanent dilatation of the alveoli, terminal bronchioles, to the alveoli. Bronchiectasis is a little bit further up. It's destruction and permanent dilatation of the small and medium-sized bronchi. So bronchiectasis is higher up, permanent dilatation and destruction of the small and medium-sized bronchi. Emphysema is a little bit further down at the alveolar membrane. So the first thing to do in this patient is to do a chest x-ray. That will tell you if you see the hyperinflated lungs in this patient, then you consider chronic bronchitis more, right? And then you go off to a pulmonary function test to document that. Or you see the crowding of the bronchi that you see sometimes in bronchiectasis. This is called tram track signs because there's dilatation of the bronchi and they cramp. So you look at this, the results of her x-ray, and you see that these patchy lucencies with crowding of the bronchi and cross-sectional ring enhancement. So this is classic bronchiectasis. The best test to document, though, bronchiectasis is a CAT scan. A CAT scan is the best test to do, the most sensitive and specific test to do, besides a biopsy, for bronchiectasis. And they did it in this patient, and they found that, they documented that, yes, the plain x-ray was really what it showed, and it showed the dilatation of the medium and small-sized bronchi throughout both lungs. So it's important in this case, that the disease that this patient had was diffuse throughout both lungs. There's two types of bronchiectasis that you could get. One is this thing called focal bronchiectasis or local bronchiectasis. And this occurs because at some point in your life or when you were small, you got a severe infection. So severe infection, usually when you were young, severe infection, pulmonary infection, things like tuberculosis, like staphylococcal pneumonia, and so forth, cause severe infection, and they destroy the bronchi. They destroy it. So now you got a part of the lung that has bronchiectasis. Well, what happens in this part of the lung? You get infections. You're not able to fight off the infections. More infections cause destruction of more lung. They cause more bronchiectasis. So it's like a vicious cycle. But this is important, because to stop the vicious cycle, all you got to do is send the patient to a surgeon. And they take out the affected lung, and the patient gets no more infections. So the possibility here is that there are forms of bronchiectasis that there's treatments for. Surgery. And this is the focal type. This is a common scenario. The one that we hear more about is this diffuse or generalized bronchiectasis that we see in patients that don't have the ability to fight pulmonary infections as much as normal people do. So they're missing some kind of mechanism in their lungs to fight off infections. Well, think about the mechanisms we have to fight off infections. It's cough, right? It's the cilia that move and kind of throw away all the microbes, right? So think about diseases that would cause diffuse bronchiectasis. Well, which people lose their cough mechanism, right? Patients with cystic fibrosis, because now they have all this plugging, all this cough that's very, very vicious and plugs. So things like cystic fibrosis would do it. Which people have no cilia? Right, things like cilia dysmotility syndromes. And one of them, if you have dextrocardia, is called cartilaginous syndrome. So cartilaginous syndrome is cilia dysmotility plus dextrocardia. And of course there's immune globulin deficiency, especially IgG deficiencies. So when you look at a patient with bronchiectasis, the CAT scan tells you what you're likely to have. Is it focal? or is it diffuse? In this patient, we saw more of a diffuse pattern. So, this occurs for all patients with bronchiectasis. You have to look for a generalized deficit. You got to make sure there's no generalized deficit. If there is no generalized deficit of pulmonary function, then you could think about this focal process here, where maybe surgical resection may be helpful. Some of these reasons that people get bronchiectasis may be treatable. For example, we know that in people with IgG deficiency, if they come in once a month and they get immune globulin, right, that's good enough. That's good enough for them to fight off the infections and don't get any more bronchiectasis. Very important. So the first step is to document bronchiectasis with a CAT scan. The second step is to look for generalized processes that would cause diffuse bronchiectasis. So things like a sweat test, right? Sweat test where you measure the chloride. If it's over 60, you find cystic fibrosis, it's something to do. To check immune globulins is another thing to do, and so forth. You go down this list. Now, people that are 43 years of age rarely get cystic fibrosis or rarely are diagnosed at 43 years of age as a first time. But what we find now, though, is people with cystic fibrosis, where they used to get diagnosed by age 10 because they used to have all these pneumonias, especially pseudomonal pneumonias. Now we find that 4 to 7% of these cases, because we liberally give antibiotics, because we have good antibiotics that take care of gram-negative infections and have good bioavailability when given orally, like ciprofloxacin, like ofloxacin. You could give these orally. Send the patient home. You'll fight off pseudomonal infection. 4 to 7% of cases with cystic fibrosis get diagnosed in early adulthood. So if they give you a patient in early adulthood and they have bronchiectasis, please don't say that it can't be cystic fibrosis because they're 17, 18, 20, 22. Wrong. 4 to 7% of these patients will get diagnosed with cystic fibrosis in early adulthood. So cystic fibrosis is still a consideration in early adulthood because of the antibiotics. Okay? That's your second step. Once you've documented one of these, you try to treat one of these. Some of these are treatable. Cystic fibrosis is not yet treatable. There are some tests, there are some studies at the NIH where they know the gene problem with cystic fibrosis. They know the chromosome. They infect the patient with an adenovirus, right, with the gene as to replicate the proteins now, and they get treated. But this is not offered to the general public. Usually with cystic fibrosis, it's symptomatic treatment. You give them these different sprays that they make their cough less hard, right? They're able to expectorate and so forth. You definitely think of them as the COPDers. They need to get their vaccines early, very important. Vaccinations in these people are very important so they don't get infections. And when they do get infections, you have to consider what? What's the organism that we always fear in these patients? That's right. You think about an acute infection or an acute pneumonia in these patients. You think about definitely Pseudomonas. Pseudomonas infections. Very important. So these people, if they have an active pneumonia, they need to be hospitalized. You need to be aggressive with their antibiotics. You need to use antibiotics for anti-pseudomonal coverage. What are the 4 antibiotics? We talked about them in an earlier session. They are the quinolones, ciprofloxacin. They're ceftazidime only as a 3rd-generation cephalosporin will get enough pseudomonal coverage. The aminoglycosides is another one, so gentamicin. And, of course, the anti-pseudomonal penicillins like piperacillin and ticarcillin. Usually, in the patient that has the pneumonia, you use a combination of two of these, because Pseudomonas is so aggressive. Okay? So that's bronchiectasis. You need to think about generalized deficiency in these people, especially cystic fibrosis in early adulthood, and cilia dysmotility and IgG deficiency. And if I remember, let's go back to this patient here. We'll go back to the further diagnostic plan. They did all the stuff that we talked about. Everything was normal. But this person actually was found to have immune globulin IgG4 deficiency. This is treatable. She comes into the hospital once a month, gets immune globulin. It's expensive, but she develops no more bronchiectasis. Okay? Please be careful, because if you get the sputum in a patient with bronchiectasis and you send it for culture, a lot of times it grows Pseudomonas. It doesn't mean that the patient is infected with Pseudomonas. You have to have the right symptoms, the right things on the x-ray to say this is a pseudomonal infection and hospitalize the patient. So you don't get cultures from the sputum unless you have symptoms. You'll get a false positive. You won't know what to do with it. Okay? The other thing that you may hear about is the rotation of antibiotics. People with bronchiectasis get infections throughout the year. So what do? Give them some antibiotics home. They take it. If they feel better, fine. Next time they get an infection, they use a different antibiotic, thus the rotation. If they don't feel good, well, they come and they see you. Okay? And the last thing, this patient had blood-streaked sputum. What's a complication of bronchiectasis? Hemoptysis, massive hemoptysis sometimes. It erodes into a vessel, they develop massive hemoptysis. What do? You either put the patient's surgery and embolize the vessel or ligate it. Okay? So I'm going to stop right there. We're going to come back after the break and continue with case 8. Okay?